Unstable and pathomechanical joints create constant aberrant inputs into the brain. Stay tuned because today you will discover why resolving proprioceptive errors requires acute attention on intrinsic muscle balance and the P1 proprioceptive primary to determine which joint to adjust to resolve cervical error into the brain. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain-based solutions so you can get better neuroplastic results with your patients. I'm honored to welcome our next guest expert. Dr. Russ Horstein is a chiropractic neurologist and has developed the adjusting to neutral technique, which is proving to resolve joint dysfunction precisely, quickly, with lasting effects. In his technique seminars, he also teaches neurologic diagnosis and how to determine which joints are creating the greatest proprioceptive errors. Today, he'll be sharing with us the P1 test. Neurologic rehabilitation starts with resolving proprioceptive errors from dysfunctional joints. Dr. Hornstein, thank you so much for joining us on the Virtual Neurology Summit. Please take it away.
Thank you, Krista. It's lovely to be here again, and thank you again for the invite. And I'm very excited to present some of this material. And what I'd like to do first is just to explain and start from the premise of what is it that happens when we have these sort of miracle cases where we've all had these cases where someone comes in, we do an adjustment, and then we see that it just changes their life. You know, they go away a different person, and they come back, and it's like everything's sort of unfolded for them, and life suddenly makes sense and everything's great. And then we also have cases where that doesn't always happen, and we end up sometimes struggling, and we have to do lots of different therapies, and it can feel like an uphill battle sometimes. And I don't think it's necessarily an error in chiropractic, or even that some cases are more complex than others, but it's just sometimes we hit the nail on the head. And so what I want to do is I just want to go through firstly a case study where we have one of those sort of home run cases. And we're going to break down how we assess that case and how we ended up getting that result, and how you can use some of the tests and the methodology and thinking that we used to understand how we can get that on a more consistent basis. So we know that when we have a joint that isn't functioning well, that it can affect our brain. We all know that. And we know that if we can get that joint moving better, that we can improve joint function, and also even autonomic function can change as well. But one of the keys, the first key of what we're looking at here is what we call congruence. And what congruence means is that when we look at how information comes into our brain, what we mean by that is proprioceptive information, the sensors in our joints that tell our brain where our joint is and which way it's moving. And even the muscles around the joints are also giving this proprioceptive input into our brain and giving us a sense of where, for instance, our neck is or where our back is. But that information is also integrated in our brainstem, in our brain, with information from our inner ear. So we have proprioceptors in our inner ear that also feed information about where our head is in relation to gravity and which way our head is moving. And that also comes together with our vision as well. So there's a lot of information that comes together, and it seems very complex at first, and in many ways it is. But all that information has to come together, and it all has to fit. All that information needs to be congruent. If we have some of that information which is not congruent, it really changes the way our brain perceives where we are or which way we're moving. And one of the best examples of that is like a cervicogenic dizziness. So when one joint in the neck is twisted off to the side, but the other joints are in a relatively good state of function, it gives a confusing signal to our brain, and we don't exactly know where we are or which way we're moving. We can't interpret those signals effectively, and it gives us these types of sensations and even, again, autonomic findings as well. So the example I want to give is of a girl that I saw about a year ago who is 5 years old, and she had persistent nystagmus. So by that, what I mean is that her eyes were flicking back and forth as though she was sort of spinning around constantly, and they had the whole of her life. So for 5 years, this girl had a constant nystagmus. She was thought to be almost blind. She was in -9 glasses. She had a very severe photophobia, so she couldn't go outside without thick sunglasses, without dark sunglasses. And she also had a lot of digestive problems as well. So when I examined her, one of the first things that obviously I saw this nystagmus, but when I started to look at her head and her eye movement, what I did was I took her head and I put her head in different positions. And when I took her head and put it forward and to the right, what happened was the nystagmus stopped. And when the nystagmus stopped, she was able to stabilize her gaze. And from that forward right position, I was able to have her focus on my thumb and actually follow my thumb to some degree. But in every other position of her head, the nystagmus was back. So I mentioned this to her father, how interesting this was. And he said, well, when she first learned to walk, she always had her head forward and to the right, and they had to train her to keep her head up. Um, and so I thought, well, this is quite interesting. And what was happening in that circumstances, that's a great example of congruence. So essentially what I did was when I palpated her neck, I found that her upper cervical was really rotated to the right. It was right anterior. And so when we put her head right anterior, not only was that same joint saying her head is right anterior, but now all of the other joints are also saying her head is right anterior. Her inner ear is saying her head is right anterior, and her eyes obviously seeing that her head is right anterior. So we actually created a static state of congruence in her brain by putting her into the position of that proprioceptive error, or into that position of where her joint was stuck. So this is really the first component of what the P1 test is. And what we mean by P1 is proprioceptive primary. So the one is the primary. Didn't want to call it PP. That doesn't sound so nice, though. P1 is basically a test where we put someone into a state of congruence. And then when you move them away from that state of congruence, you're actually adding more proprioceptive errors into their brain, and we can see certain things happen. So I'll get into that in a moment. But what I first want to do is explain what we did in that case is I had her in that forward anterior position. And what I did was I got right in front of her. So I had her head forward and to the right. So I'm holding her head forward and to the right, and I'm staying right looking at her. And as I tried to move her head back towards a neutral position, what I did was I stayed down and to the right. So as her head came back to a neutral position, I was actually forcing her eyes to actually go down and to the right, as I brought her head back. And when I did that, what ended up happening was her neck tightened up. We call it a cervical colic reflex. And effectively, what was happening in that circumstance was as I moved her back, instead of her just keeping her eyes in that position, I was requiring her brain to perceive where her neck was from the proprioceptors, through her inner ear, and from the joints. And as we started to move her from a state of congruence, where everything was in agreement, to a state where there's a disagreement of the proprioceptive input, her brain didn't know where she was. We suddenly started to push her into an envelope where things didn't make sense anymore. And what her body did was elicited a cervical colic reflex. In other words, her neck just tightened up like it was in concrete. So this is how the P1 test works. Let me just tell you what happened with this case and how I treated her. So what we did was her neck was right anterior, and I started asking questions about what may have happened to her. And it turned out that she had had a very traumatic childbirth where they were pulling on her head to get her out, and clearly did something and stretched the muscles in her neck in a way that made them less capable of contracting and stabilizing. So what it did was it left her kind of in that traumatized position. So what we ended up doing was seeing that her joint was right anterior. And the way we resolve this with adjusting to neutral is we start from that position of where that joint is subluxated. So in other words, wherever that muscular imbalance is pulling the joint, we start from that position. And what I did is I took a contact and drove the joint back towards a neutral position, and effectively stretching the muscles that were resisting the joint to come back to neutral. And we had a lovely cavitation, the joint released. And in doing so, we can create a change in those muscles. We'll go into it in more detail in a moment. But we created a change in the muscle response and the reactivity of those muscles such that now there was a balance of those intrinsic muscles, such that she could go back to a neutral position in that joint. And then also with a balance in those intrinsics, her mechanics were functioning more appropriately as well. So what we've actually done is our adjustments can actually resolve those proprioceptive errors. So just as a trauma and the force of a trauma and the stretch of a trauma can make a muscle less capable of contracting, we can also find a tight muscle and just as well and stretch that muscle effectively and to drive it back towards a neutral position and reinstate that balance. And in doing so, her joint was now stable and biomechanically functioning appropriately. So one of the things that happened immediately after I adjusted her was she sat up and looked at me with this kind of slightly startled and amused look on her face, but she looked directly at me without nystagmus. She then stood up on a sofa, on the back of a sofa in the room, which had a rigid back, and walked across the top of the sofa like a gymnast with one foot in front of the other without even looking at her feet, and just walked perfectly straight. And her dad said, I'll paraphrase, what the F just happened there? Because he had never seen her do that. This is a girl who was falling over all the time. So, and then she just continued for the next few minutes to walk around the room, walking in straight lines and really enjoying being able to know where she was and how her body was moving. So what else happened was, as I mentioned before, she had some autonomic problems. So when we first assessed her, we saw that her pupils, she was very, very photophobic. So her pupils were absolutely, completely dilated. And when I examined her gut before, there was no gut sounds, no gut motility. And she had a lot of bowel problems and food sensitivities. After we adjusted her, we took her back into a darkened room, shone a light in her eye, and which she had reacted very strongly to before, but in an aversive way. But now the pupil is constricted, and she was fine with that. So, as well, we listened to her gut motility, and the gut motility had returned, and beautiful bowel sounds, and all of her digestive problems went away. She didn't have photophobia anymore. She didn't have nystagmus anymore. And a year later, she's still functioning well. And that was just with one adjustment. So, I'm not trying to pat myself on the back, but just to say that this is a miracle case, but it's also one where we were able to determine what was that primary proprioceptive error and to be able to know that it was actually that joint that was creating the greatest errors into the system. So what we mean by proprioceptive error is that there's basically an imbalance in a muscle. So this is kind of also another definition of a subluxation, where you have an imbalance in the muscles around the joint that are prohibiting the joint from moving as the brain is directing it to move. So when our brain sends a signal to make muscles contract to move a joint, it expects to receive feedback from that joint, sensory feedback that says, yes, I've actually moved that way. Whereas when we have a subluxation, the brain will still be sending signals for that joint to move as it intends to. But when there's an imbalance of these intrinsic muscles, it becomes very, very difficult for the body to move that way. So the feedback that comes back says, I didn't do what you told me to do. And so that's what we mean by a proprioceptive error. So when we have these proprioceptive errors, it also does affect our autonomic system. And so I want to explain how that happens as well. So whenever we're moving, we're expecting to get a certain feedback that says, yes, I move that way. But when we get a different feedback, this proprioceptive error has an effect on our autonomic system as well. So what we'll find is actually another example of how that could work is that if you're walking along and you're taking steps and you put your foot in front of you, you're expecting to feel your foot in front of you as you weight up your foot and you go to the standing phase of gait. But if, for instance, the floor was slippery and your foot moved away from you, you'd be getting a feedback to your brain that your foot isn't where you asked it to go. And what will end up happening is you'll know that that's an incongruent information. The rest of your body is saying everything's fine, but then suddenly your foot moves off to the side. You might even sense your body starting to move in that direction, and it's incongruent with what the command was. And that incongruence is what drives our sympathetic system. So we know that we have autonomic control that controls blood pressure and pulse and pupillary size and all these things. But when we have an incongruence in the system, your foot slides out, you need to have a different response. And that response has to be a self-preservation response. So you don't want to go down. So what your body will do is it will increase your pulse, it'll dilate your pupils, it'll take energy from its stores in your body and get it out to your muscles very quickly, and it'll increase your reflexes. And all of this is a sympathetic activation, and all of it is meant for self-preservation to keep us from going down, to keep us from falling. and we rely on that incongruence to drive that system. So if we have a joint that is incongruent, which in this girl's case was the upper cervicals, where there's a great density of receptors, where there's a lot of receptors, it's basically giving a lot of very, very strong errors into a system where it's in conflict with the other proprioceptors. So she was really having a big, big drive of her sympathetic system all of the time because, again, it was just saying, I'm not where you're telling me to go. So that sympathetic drive is really activating that system, so much so that she wasn't able to exhibit any parasympathetic function of pupiloconstriction or activation of her gut because her body, again, was so sympathetically dominant that it was driving the other direction. So as soon as we were able to not only afferentate that joint and getting it moving again, but also getting it to move appropriately, we're able to resolve that error so that she wasn't necessarily activating that sympathetic system anymore. But because there's so many receptors in the upper cervicals, if the joint is stuck, you're actually getting less afferentation as well. So once we get it moving, she's getting more afferentation. And our brain really relies on afferentation to really drive the higher centers of our brain as well. So simply getting the upper cervicals moving was also very conducive to driving cortical and prefrontal cortical areas of our brain. And those are the areas that are really the seat of our parasympathetic function. So not only were we resolving the errors and taking our foot off the accelerator of the sympathetics, we're actually helping to drive higher centers in our brain to switch on parasympathetic control. So this is why that works and why we see such a close connection between autonomic failure or imbalances in the autonomic system when we have proprioceptive errors. So any proprioceptive error just means that the joint isn't moving the way that it was being told to move, and in which case we'll see a lot of these types of responses. So the idea of understanding what congruence is can be a very, very valuable tool when we know how to assess and incorporate it into other testing. So the idea of a P1 test is really an incorporation of understanding how proprioceptive information comes into our brain and helps us to coordinate our head and our eye motions. So head and eye motions can be very, very complex. There's kind of two main types of head and eye coordinated motions. One is called the vestibulo-ocular response, and that's a response where your head and eyes move in opposite directions. So if the head moves to one side, the eyes move to the other side. That should happen very, very quickly. It's almost an instantaneous type of response. But it really relies on information coming from proprioceptors telling us where our head is and which way it's moving. So we rely on the semicircular canals and the otolith in our ear, the stretch receptors and load receptors in our muscles, and also the pressure and movement sensors in our joint capsules. So all of that information has to come together to know where our head is to be able to have that coordinated function. So it can be quite complex. So if we have a proprioceptive error, we can actually start to detect failures of the vestibulo-ocular response. Now, being able to detect that clinically is really a practiced art, and it's something that confuses even people that have been into neurology for as long as I have, or even longer. It can be very, very complex. But what I've realized is we can actually incorporate two different types of head and eye motions to create the cervical colic response, which is again an indicator of a proprioceptive error. And we should only see that when it's a proprioceptive error that's kind of messing with our brain and how all of that information is coming together. So again, what we do with the P1 test is you can move the head into a position and have the eyes doing different things. So I said how there's different types of head and eye motions. So one is a VOR. Another is like a head-eye saccade, where your head and eyes go in the same direction. We primarily use that for fast motion. So if you hear something over here and you want to look at it, your head will move part way and your eyes will move part way. So head and eyes in the same direction is another type of head and eye response. But in between the two, you can actually do head motions, where we call it VOR cancellation, where your head and eyes move in the same direction at the same time. So you might be moving the head, but the eyes actually don't move, and the eyes stay still. That's a VOR cancellation. So what we do in the P1 test is you take the patient's head in your hands, you hold their head, and you have them look at you. And then what you can do is as you move their head, you move with them. As you're moving with them, we call that VOR cancellation. And what they're doing is you're giving them information about proprioception that's going into their brain, and the command is just to relax. So you're not actually requiring them to do anything with their muscles. They're trying to relax their muscles, and you're just moving their head. Okay? And that should be a relatively easy thing for most people to do. Sometimes as you're moving them, you'll feel a little bit of resistance, but we're looking for something different. What you do is you move your head into different ranges of motion, and I like to do it in a LARP-RALP formation. So in other words, rather than just left and right rotation and up and down, I like to move them LARP and RALP, which is left anterior, right posterior, and right anterior, left posterior. And these are more kind of typical planes of motion of how our body works. We don't typically go simply in flexion and extension or lateral flexions. We move in these kind of LARP-RALP orientations, and our joint mechanics are meant to move in this way as well. So if you take their head, in the case of this girl, right anterior, that's a normal sort of motion. And if I'm moving forward, so if I take her head right anterior and I move with her, so her eyes are staying with me, it should be a relatively easy thing for her to do. Her proprioceptors are sensing this, and I'm going to be moving her through areas of congruence and less congruence or incongruence. If I take her into a state of congruence, and then I stay there and I move her back to a neutral position, what I do is I go from a VOR times 0 or VOR cancellation, where eyes are just staying still, to a test where I actually move her head and I'm asking her to sense where her proprioceptors are, okay, which direction her joints are moving in, and to move her eyes in the opposite direction. Okay, so I kind of trick them from going from a VOR cancellation where you're moving with them and you come down to one of those positions and then you stay there and you move their head back. And so she goes down like this, and as you move your head back, her eyes have to go down and to the side. And that is a much more complex motion to achieve passively when you're introducing proprioceptive errors. So in that case, when you're doing the P1 test, that's what the P1 is you take them into that position, and then you stay there and you move them back. And if you feel that their neck just feels like it's in cement, that's a positive P1 test, because what's going to happen is their brain is being introduced to more proprioceptive errors. So you're taking them from a state of congruence of that, say, right anterior, into a state of less congruence, and you're introducing proprioceptive errors. At the same time, you're asking them to respond to proprioceptive inputs and move their eyes in the opposite direction. And the body doesn't know how to do that. So what it does is it just locks up the muscles. So that cervical colic reflex just means that their neck just tightens up. So this is a very, very simple test. And I have videos online on my channel where people can see how to do this. And so I can explain it in more detail. But basically what you're doing is just taking their head down and you're moving with them. And then you go into this position, move their head back. You go to this position, move their head back. This position, move their head back. This position, move their head back. And usually in one of those positions, you'll find that the joint will feel like it just locks up, like the muscles tighten up. If it tightens up, it's because you've gone from a state of congruence to a state of lesser congruence. In other words, you've taken them into the proprioceptive primary error, okay? And in this case, it was that girl right anterior, and we take her away from that position. We're introducing more errors, and we get this response. So it's a very, very simple tool and test you can do, but it's also something that's quite reliable as well. So it's kind of something that I've invented in a way, but it's just using the tools that we have. So people that are in neurology use VOR, they use head-eye saccades, and we use VOR cancellation to try to discern where there is an error in the system. But if we can get our head around the idea that we're actually creating congruence or incongruence in the system, then we can actually use that boundary between congruence and incongruence to draw out some other type of response. So, another example of how we can do this is I was with a neuro-optometrist a few weeks ago, and we were using a Maddox rod, which was basically a test of eye alignments. And we saw patients that had eye alignment failure, and we put their head in different positions and saw failure, failure, failure. But when we put them into the position where there was congruence, in other words, where the joint was stuck and all the joints were in agreement about where they were, suddenly the eyes were in alignment. And that was a case where the proprioceptive primary, in other words, the joint was stuck, and only in that position could the eyes be in alignment. And when we took away from that position, we saw misalignment of the eyes. So it's kind of like this lurking function inside people. And I think it's probably the reason why we see things like head tilt sometimes, because people will tilt into a position where they can kind of reduce the overall errors in their system. So it kind of puts a little bit of a different slant on what we're doing. And obviously, we're actually quite right about if you see a head tilt, just straighten it back up again. But if we can determine which joint it is, then it gets much, much easier. So again, in that circumstance, if we see that the proprioceptive primary is in one direction, all we have to do is put the person in that position of that where they're showing up with a positive P1, and then you just palpate the joint and you feel where you feel which joint you feel is a resistance to come back to a neutral position. And then what we'll do is just take the joint from that position and we adjust it with adjusting to neutral. We do this and drive the joint back to a neutral position, reset the gain of those muscles, and then we see a greater balance that should persist. So anyway, so that's the main focus of it, and I'll leave it to you to ask any questions you might have about that.
Wonderful. Dr. Hornstein, thank you so much. What a great presentation. Thank you for sharing that great case study that really set the tone, literally set the tone of a great case study to explain the P1 and adjusting to neutral. So I'm going to go through a quick review and then a couple questions for you.
Sure.
So you said when a joint isn't functioning well, obviously it impacts the brain, and improperly moving joints can also impact the sympathetic nervous system. So we're looking for congruence, where you give proper proprioceptive input with proper integration from receptors in the inner ear, the visual system, as well as the brainstem, and all information needs to be congruent. If not, we don't know where the body is and in which direction it's moving. A great home run case study, 5-year-old girl with constant nystagmus. I mean, just hearing that, you can already just imagine how uncomfortable that would be for that little girl. She expressed severe photophobia, digestive issues, and then when doing forward and to the right, nystagmus stopped. So you were moving her through the positions, you moved her head forward and to the right, and then nystagmus stopped and she was able to gaze stabilize. Every other position had nystagmus. And then trained her to keep her head up. So when she was learning how to walk, she was trained to keep her head up instead of in that forward anterior position that actually allowed her to gaze stabilize. So she had been trained out of the position. And then she presented with a right anterior cervical rotation. So you put her into the position of proprioceptive error, and then congruence, and then testing for the P1 proprioceptive primary, and then stayed down and to the right while moving her head back to the neutral. So she was looking at you, and then you moved her head back into neutral from the correct position, and then she had the cervical colic reflex as a response. So it went from congruence to non-congruent state, which led to the cervical colic reflex, and she had traumatized position from birth. And it's amazing because patients are living with these things for a long time. And this was a more severe case, but even just moderate, changes of the proprioceptive system, may have been living with for years before. And then start from the defective position and then adjust back to neutral. So create change in the muscle response, allowing balance of the intrinsic muscles. And then she also had autonomic dysfunction, such as dilated pupils, decreased bowel motility. And then you were able to see that she was able to control her pupil dilation, so she wasn't so photophobic, as well as had good bowel sounds. And then determine primary proprioceptive error, and then that joint created the greatest error into the system, and also imbalance of the muscles around the joint. So the brain sends signals to the joint to move. The feedback is dysfunctional back to the brain when there's an aberrant joint space or aberrant joint function. And then proprioceptive error impacts the autonomic nervous system. So incongruence drives the sympathetic nervous system, and it's a self-preservation response. You give a great example of if you put your foot forward to take a step and you slip a little bit, that's incongruent information. And for self-preservation, we're going to respond. So incongruent joint where there's a lot of errors creates conflict and sympathetic nervous system overdrive. So we want to afferentate the joint, which can resolve the error. The brain resolves on the brain thrives on afferentation to drive cortical and prefrontal areas of the brain and switch off that sympathetic nervous system overdrive. And so with the P1 test, it's how proprioceptive information is integrated with head and eye movements. So with the VOR, the head and eyes move in different directions. We rely on the otoliths, semicircular canals, and the cervical muscle spindles. So move the head into the position and have the eyes do different things. So move the head and move eyes in the same direction with a quick saccade, also doing a VOR cancellation. So when you do the P1, are you moving them in all directions and doing a VOR cancellation as well as with a quick saccade? Do you do all
You can do head and
directions?
eye saccades as well, but generally we're just looking at the VOR and VOR cancellation.
Got it.
So you're doing it passively with the VOR cancellation, and then when you get into the end range of each of those LARP quadrants, what you do is then you stay in that position, and as you move them back, you're actually going from a VOR cancellation to a VOR, where they actually have to move their eyes in the opposite direction. And as you're introducing that proprioceptive error, we see the cervical colic response.
Yes. And that's going to be the positive test when you get that cervical colic reflex.
Yes.
And
Yep.
so we're going from congruence to lesser congruence, and then we're seeing that cervical colic reflex. And then you could also test a great example of how you had tested eye alignments with different positions as well. That you had tested that there was
Yes.
misalignments with the eye function, and then putting them into the proper position, and then seeing that they were aligned. And then put the person
Exactly.
in the position of P1, palpate the joint, and then adjust back to neutral. So find
Yep.
the position and then adjust them back into that neutral position.
Yep.
So
Exactly.
phenomenal. What a breakthrough. And I know that it's quite complex, the neurology around it, but it's an easy test that allows you to find the correct position and then
Exactly.
adjust them, like you say, which is your technique back to a neutral position. I have a
Exactly.
question for you. When it comes
Sure.
to after doing the adjustment, do you then redo the test, the P1 test, to see if
Absolutely. Yeah. Not only that, we redo all of our neurologic testing. So any testing that you're finding, another thing that I didn't really bring up, but it's kind of coming out now, is that if you don't know where you are, we often see a breakdown of motion as well. So smoothness of motion is a really good indication that you know where you are, so that as you're moving, you can control that motion very precisely and easily. If you're moving in a vector of motion where you don't know where you are, you see this jerky sort of motion. So smoothness of motion is a really, really great indicator. In the seminars, we have many, many tests we do, but they're really all neurologic tests to see how well that system is functioning. So one of the things I really wanted to add to this as well is that if we have someone who has proprioceptive errors and we haven't found which are those primary ones and resolved it effectively, you have a patient sitting in front of you who's getting all of these errors all the time. And if we start to then apply some type of stimulation or some type of a challenge into their system where we're trying to build function, but at the same time, you're actually stimulating a system that has all of these errors, we're not actually going to be able to resolve those errors with that function. We're trying to drive function into a system that has errors. And the best that we can do is actually build compensations, which isn't really ideal. So in other words, we still have the errors, but you're kind of building a function on top of that. And that's what we call a compensation. When we can resolve those errors, now you're getting clear signals, and any therapies you apply thereafter will have a much greater impact because the system now doesn't have that stress of trying to manage what's real, what isn't real, where am I actually, how am I moving? Suddenly everything becomes much more powerful. So the therapies will become much, almost exponential in their power. So I really wanted to kind of highlight why doing this first is really should be the first step of our neurologic rehabilitations.
wonderful. So you do the first adjustment, then you're rechecking, and then it allows for more effectiveness with further therapies.
Yep, absolutely. So very often what we'll find as well is that we should see an immediate change. So it isn't something that you kind of have to wait for a while for. A lot of these neurological things will change very quickly because as soon as you resolve those proprioceptive errors, you just pull it out of the system and it's just going to start working differently. Now, obviously, some of those changes will be plastic. And like I said, there's also compensations that will happen as a consequence. But after we treat them, what we're looking for is to see how quickly those autonomic things change and how quickly and how much of those compensations resolve. So when we reassess the patient afterwards, then we're looking and seeing how the system is adapting to new inputs. But obviously, sometimes there's joints that have been like this for a long time. There'll be bony changes and other effects. So we can kind of pick your way through and work through other joints. But generally, the changes that we're making in the joint, if we drive it back to neutral, those have a longer lasting effect. and primarily because the stretch that we're applying is directed to the intrinsic muscles. And the intrinsic muscles, the slow twitch muscles, have a long response time to a fast stretch, which is exactly why traumas tend to last. You stretch a slow twitch muscle, it's going to have a lasting effect. So if we can stretch a slow twitch muscle and resolve it, then we should also see a lasting effect.
Would this also be why patients have chronic postural distortion patterns? You put them in the
Yeah.
right position, but because their intrinsics have been off, they have they continue to go back into the aberrant position.
Yeah, absolutely. Yeah, we see this a lot. So, what can happen is obviously our postural muscles are controlled through those vestibulospinal pathways as well. So, we have the medial vestibulospinal to the spine and lateral vestibulospinal to the extrinsic, to your extremities, and particularly to the extensor musculature and the slow twitch fibers within those muscles. Um, but if that system is not being giving good quality information, we don't know quite how to respond. So that even a very, very reflexive system doesn't even require our thought, will be interrupted by these aberrant signals. So we'll usually see that the output of those vestibulospinal pathways will drop when we have aberrant input coming in. I can give you a very, very quick review of another case that had this, where it was a woman who had been in a wheelchair for 40 years after brain surgery. And I thought that it was something to do with the brain surgery. But what happened was during the brain surgery, they had her neck in such an awkward position. They subluxated her neck and she lost all postural tone. And when we adjusted her joint, we basically switched the postural tone back on. And she went from being slumped and unable to stand to literally just being able to have good posture and standing straight away. So she literally walked out of the room and after having been wheeled in. So a lot of these things can
That's
actually
another
happen
home
quite
run right
quickly.
there.
Yeah, yeah, it's fun. But I mean, you know as well. I mean, you're very well versed in understanding how the postural system works. And if we can resolve these errors and be very directed and precise with our treatments, we should see changes very, very quickly. The only thing that has to catch up is just kind of how much ingrained those compensations are.
Sure. Wonderful. Well, thank you so much for sharing this with us. I know we're going to want to learn more about your seminars. Can you tell us where we can learn more from you and also watching your videos online?
Sure, yeah, absolutely. So I have a lot of information on YouTube. So you can just type in Russ Hornstein into YouTube and you should see my channel. And I have a lot of informative things. It's mainly for doctors, but it's kind of also general knowledge things as well. You can check into adjustingtoneutral.com. We have all the information about our seminars there. So we're doing seminars all over the world now. We're now going to be doing some more in America. We're going to Australia. We're all over Europe. And what we're going to be doing is in the fall, introducing a hybrid system as well, where people can do a lot of the lectures online and then just simply come to a practical session and learn all the practical tools and practice practical tools. So that'll be new opportunities for people that are coming from farther afield. So we're really excited to introduce that soon as well.
Yes, absolutely. And I want to encourage everybody to check it out and learn more. And as we wrap
Excellent.
up another great session today on the Virtual Neurology Summit, I'd like to acknowledge Dr. Hornstein for his excellent work in functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host on the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.